Well, that's a great question. So the ADA-EASD guidance on the management of hyperglycemia, last time it came out in 2022, was also here at the American Diabetes Association meeting. And for the first time, we started to talk about holistic care, so more than just glucose management. Here, there's a further expansion of holistic care for patients or people living with type 2 diabetes to not only include cardiovascular disease management and sort of using disease-modifying therapies like GLP-1 receptor agonists and SGLT-2 inhibitors for cardiovascular disease, a bit more detail about heart failure as a condition as well as chronic kidney disease, but then branching to further areas, fatty liver disease, and mentions of cognitive dysfunction and osteoarthritis and other areas where these drugs have been shown to have benefits. Beyond that, there's a call for more routine and earlier use of GLP-1 receptor agonists and SGLT-2 inhibitors. So quite explicitly, a suggestion that GLP-1 receptor agonists and or SGLT-2 inhibitors should be considered from the diagnosis of diabetes with the idea that they're disease-modifying agents. And obviously, if someone is diagnosed after a heart attack, so they went to the emergency room with chest pain, and during that hospitalization, they were discovered to have diabetes, the rationale for using a GLP-1 receptor agonist or an SGLT-2 inhibitor or both is much, much stronger than a 24-year-old laborer who goes to the emergency room because he has an infection on his hand and they just check an A1C, make the diagnosis of diabetes. There, one might quibble about whether a GLP-1 receptor agonist or an SGLT-2 inhibitor is the ideal drug or not. But what we're suggesting is that you should at least consider doing it. And personally, as just one member of the writing group, if I were diagnosed with diabetes or my child was diagnosed with diabetes, I do think the logical first drug therapy would be a GLP-1 receptor agonist or SGLT-2 inhibitor. So I think those are the sort of the shifts. Nothing revolutionary. It's only been 4 years. We have more effective drugs now than we had 4 years ago in 2022 when we were writing the last one. But there hasn't been revolutionary advances that demand revolutionary change. This is incremental and more of a shift in understanding. But if you look back 6 years ago, very explicitly, the guidance was you're diagnosed with diabetes, it's lifestyle therapy and metformin. That's the first line therapy. And if you look back 20 years ago when we had the first of these, this was inconceivable that diabetes care would have evolved in this way. So it's exciting to have been involved over the last 20 years in these guidelines. Then one really important caveat is that this is a first reveal of the document. It will undergo peer review and review by sort of the responsible committees at the American Diabetes Association and at the European Association for the Study of Diabetes. And it is quite possible through that process that there will be changes. So what I'm telling you today may not turn out to be true when the final document comes out in association with the European Association for the Study of Diabetes meeting in Milan in September. Yeah, and that's a great question and kind of complicated for just a few minutes to get the words exactly right. But in this document, there's very clear language around patient-centeredness. So the decisions that we as providers make need to be in concert with the people living with diabetes, taking into account their values and preferences and issues like economics and medical issues. So it involves a lot of inputs into that decision making. But as an example, in people at high risk of cardiovascular disease or with cardiovascular disease, quite explicitly the language is that they should be on a GLP-1 receptor agonist with proven cardiovascular benefit, or an SGLT-2 inhibitor with proven cardiovascular benefit, or both. For instance, in heart failure with preserved ejection fraction, similarly, those kinds of choices for drugs. In people with reduced ejection fraction, a preference for SGLT-2 inhibitors. In chronic kidney disease, SGLT-2 inhibitors and or GLP-1 receptor agonists. In MASH and MAFLD in liver disease, preference for GLP-1 receptor agonists and consideration of using SGLT-2 inhibitors, pioglitazone, and a new thyroid receptor agent as considerations. So there's a lot of details. Again, there's discussion now for the first time of drugs like finerenone and other agents being not glucose-lowering agents, but that need to be part of the thought process in individualizing care. So they're not directed at lowering glucose, they're directed at improving outcomes in individuals with particular conditions.